Sinead. So, I mean, it will be there, if people come in late and they miss the beginning, or if Aisling wants to send it out to anyone who couldn't make it today. Uh,
Sure. Yeah.
So good morning, everybody. And good morning, Sinead. And for those who will be joining us by recording, and who those who want to join us later, and I can see some of colleagues are on already. It gives me great pleasure to introduce Sinead Frain. Sinead is an advanced nurse practitioner in Dublin West Southwest Mental Health Services. She is a friend and colleague of both the RCSI and the faculty of Nursing and Midwifery, and indeed ourselves, the Psychiatric Nurses Association. She has been with us on this journey of RCSI, PNI, CPD webinars for the last 3 years, always making sense to take some of her title with regard to this morning's title, which is actually helping patients make sense of their illness. Well, we haven't seen Sinead since I think it was towards the end of last year, so really looking forward to hearing from her again, and indeed making sense and all those practical pieces and intuitive knowledge and indeed broad knowledge that she brings to her scope, her role, and the advancement of psychiatric mental health nursing. So I'll pass to you, Sinead, and thanks a million for joining us. Lovely to see you again. By the way, this is Aisling here from the PNA. Thanks, Sinead.
Thanks so much, Aisling. It's a pleasure to be here again. I love this bit of teaching. I really enjoy it, and I love sharing the knowledge that I have built up along my way and my journey at work. So what I might do is not delay very much. I am going to turn off my camera and I'm going to go straight into the presentation. And I will take questions at the end, so it's not a problem if anybody has any questions. They can just put them into the chat box. I think Anya's going to keep track of that, and I'll take the questions at the end. Okay,
Great,
I'm going to
Sinead.
just
Thanks a
turn
million.
my camera off and start with the presentation. Okay. Okay, so today's presentation is just about how, as part of my role, I help people to make sense of their mental distress. And I think that, excuse me, it's really, really important when we're looking after people in times, especially of crisis, and when they come to our service first, they're often very bewildered as to how they have ended up in the psychiatric services, what has happened in their lives that has taken them to this place. And if we can help people make sense of their distress, I think it's just really important. For some reason, oh, there we are. So why, in terms of helping people to make sense of their distress, I use a technique called normalization. So when we look at normalization with people, it really is to try and explain to people what is happening. When people arrive into our service, it's like a lot of the time it's the worst thing that has happened in their lives, and it's just a complete catastrophe for them. So it helps people to decatastrophize their experiences and their mental distress. And it also helps people to be hopeful and optimistic about the future, and that there is a possibility of recovery. When I normalize with people, it actually creates so many opportunities to build upon the therapeutic alliance that I have with them. And actually, it helps people feel a little bit more normal. Like, people do often say, I've lost my mind. How have I arrived in this place? Like, am I mad? I've lost my mind. And also, probably, one of the strongest points about, helping people to normalize is that it provides a rationale for the care plan that you're putting out for somebody, that you're developing with somebody. It just provides a rationale for everything that goes into the care plan. That will all become a little bit more evident as we move through the presentation. Sorry, no, this is not moving on for me. Sorry, Anya.
Sorry, Aisling, if you just try, can you see the arrows?
Next page, hold on now. Why is that stopped? Oh, there we are. I don't know why it's behaving like this. Apologies. Okay, so.
Oh, I was just going to say, if it happens again, just maybe try unshare and share again, and that might help the situation.
Okay, thanks. Okay, so why do we normalize? And this is, I suppose, the theory part behind it. Okay, so according to Beck, when he was developing his CBT, it's an integral part of CBT. So, providing explanations as to, A and B has caused C is just really important for somebody. And there's several other authors that I have listed there that also think that it's important as well. So why is it, so important? So people often have strange experiences as a result of stress. And, stress is really, plays a huge part of why we develop mental illness. So they experience anxious and depressive cognitions, all right? And this may increase, these cognitions may lead to hyperarousal, so they're paranoid, or social withdrawal. So they're going, oh my God, this is all so weird. I'm just going to stay at home and I'm going to not see my friends and I'm just going to sit out because I feel safe at home. It also leads to an increase in the frequency and duration of experiences of mental health. And all of these things, as I said, lead to a decrease in engagement and social functioning and sometimes medication compliance. And the stressful experiences oftentimes lead to an increase in a person's experience of hopelessness. Okay, so once upon a time, and when I was training, it was like, don't delve into people's experiences, certainly don't collude with their delusions. And, how many times does somebody come to us and they go, I just need to book up. I just need to book up my ideas now and just pull myself together and I'll be fine. So if you don't talk about things, if we don't acknowledge things or nod to them and go, yeah, this is happening and it's awful, then the catastrophizing happens and people develop awful cognitions about the place they find themselves in. And oftentimes, like, how many times do we have people who come our way who go, I am taking my medication, but here I am, I'm sick again. So there's rarely a biological explanation, just a pure biological explanation as to why people have mental health distress. So if we were to look at mental health on a continuum, so you'd have healthy mental health on one end and mental illness in the middle, and somewhere, or mental illness at one end and health at the other end, and somewhere in the middle there's stress and anxiety and emotional problems. So they all sit in the middle. So and it's a continuum. So what that means is sometimes we're healthy, sometimes we're somewhere in the middle of it, sometimes we swing to the end over to the illness side, and we swing back again. So it's a constant continuum. We are constantly always moving up and down that continuum. Some days are better than others, some weeks are better than others, some months are better than others. And I absolutely love this this quote, and it's from Mind in the UK. So every single one of us, I think it's important, and I think it's important that we let our patients know this as well, that every single one of us, given a certain set of circumstances, become very vulnerable to becoming mentally unwell. So the quote is, we all carry within us the seeds of our mental health problems. Those who suffer severe forms of mental distress are no problem. It is only because they have been subject to an environment that has allowed their seeds to flourish. So if we can't be aware of what triggers our stress and our mental ill health, then it just grows and grows and grows like a seed that's allowed to flourish. It's the perfect growing environment for it. So if we look at normal beliefs, and abnormal beliefs. So when we say that any one of us, given a certain set of circumstances, can develop mental signs and symptoms of mental illness, I'm just going to go through them there. Okay, so people become psychotic in organic confusional states. So if somebody has a delirium, they can be psychotic. If somebody has taken drugs, they can become psychotic. If somebody is withdrawn from alcohol, they can become psychotic. And all of these people here, so Wilcox, Oswald, Slade, they all carried out experiments on regular people. Oswald deprived people of sleep. Wilcox looked at people who had post-traumatic stress disorder. Slade looked at people who who were deprived of their senses. So all of these people looked at people who, Maria, didn't have mental illness, but they all developed psychotic symptoms. So the Oswald study was a big one. He deprived people of sleep for hours and days on end, and people actually did tip over into a psychotic state. So I suppose what I'm trying to say in this slide is that there are certain circumstances that not necessarily have anything to do with being mentally unwell. If you're in a hostage situation, it's nothing to do with being mentally unwell, but being exposed to this sort of a situation can lead to the development of symptoms. Cultural beliefs. So atheists stand and look at people who believe in God and go, that is absolutely mental. Like there's no such thing as God. People believe in horoscopes. People are superstitious. Like how many people don't walk under ladders? People believe in voodoo. And I suppose what we're seeing in this country now with the influx of our migrant populations, they have very different cultural beliefs to we have. And a lot of the time, you know, the medicine man can come in and do voodoo on somebody and, you know, things are better, or somebody has cast a spell on me. So sometimes people's mental illness sits within their cultural beliefs. And I think it's important as well to know about that. So Cox and Cowling here surveyed 60,000 British people, and they found that, you know, 68%, maybe it's less now because it's quite an old study, believed in God. You know, 23% of people believed in horoscopes, 10% believed in black magic. So, and you know, so we need to look at where it all sits in terms of cultural beliefs of people as well. So if you just think about, you know, has there been an occasion when you felt like you were low in mood? You know, and what did that feel like for you? Or if there's been a time when you've been extremely stressed and extremely worried, and what did that feel like with you? And could you imagine if that continued unabated? You know, where do you think you would have ended up? Do you have any irrational fears of situation or objects? Like people are afraid of clowns and balloons. Like to me, because I'm not afraid of clowns and balloons, that sounds like madness. But there are people who are genuinely afraid of such things. You know, and have you ever held beliefs that are unusual or unscientifically proven? You know, if you break a mirror, it's 7 years bad luck. How many of us will salute a magpie? I do. Like, I do it. It's absolutely bananas that I do it, but I do it. How many people won't walk under ladders? Or have you ever had any experiences that are difficult to explain? So there are times during all of our daily lives when, you know, the normal is abnormal. It just depends on what lens you look at it through. But it's important to unpick and make sense of it all. So just in terms of what's normal and what's not normal. So this is the Necker cube, all right? And if you were to sit and stare at the red dot in the far corner for a while, what would happen? So, you know, while you're sitting and looking at it, I'll go through the explanation. So the cube appears to flip, and the red dot sometimes is on the inside of the cube and sometimes it's on the outside of the cube. So when you look at this drawing, and it's a 2D drawing, your brain automatically visualizes it as a 3D drawing. But it doesn't, the drawing doesn't give enough information to your brain so that your visual system, excuse me, can know exactly which face of the cube is at the front. So the ambiguous cube shows us that anything we see is just a best guess by our visual symptom. So basically, your visual as to where the dot is it at the front or is it at the back? So your visual system forms a hypothesis that the cube is at one orientation and then suddenly it appears to be at another orientation. And we can never see both orientations together because our visual system has to decide between the dot being at the front or the dot being at the back. So the next one, is this a picture of an old person or is it a picture of a young person? So if you sit and look at it for a minute, depending on where your eyes are drawn, the picture doesn't change, but how your brain interprets it is, you know, it changes. It can be in two different ways. I don't know. Emma, can you turn off your mic, please? Thanks. Okay, so the picture doesn't change, all right? But when you look at something, your eye and your brain have to decide in a split second what it is. So your brain makes its best guess, and it usually gets it right, okay? So, but in this picture, your brain can't decide which is the best guess. So the picture appears to flip between the two options. So whether or not you see the young lady or the old lady depends on where you look. So if you look at the eye and the ear, it provides strong evidence that it's an old woman. Whereas if you look more to the left of the picture, there's strong evidence that it's a young woman. So who is it that you see? Now, actually, that I arrive at slide 15, I realised that I forgot to put the picture in for that one. So apologies. That was something I was to come back to and I totally forgot. Okay, so this one. If you sit and look at this picture for a little while, all right, so stare, actually this is the picture. So you stare at the blue dots, yeah, for about 30 seconds. What do you see? So now do it again for 30 seconds. So I want you now to look at a white wall. Do you still see it? So what happens in this picture is most people see an apparition of a man, perhaps Jesus. Okay. When you look at the white wall, the image appears much bigger. So why this is because staring at bright white areas of the picture tires out the eyes and the light sensitive areas in your retina at the back of your eye. So when you closed your eyes or looked at a white wall, you see a negative after image so that the areas that were white were now black. And this one here is about counting the black dots. So sit and look at your screen there and try and count the black dots. And what you will notice actually as you're staring at it is that it's impossible to count the black dots because as soon as you focus on the black dots, they disappear. So your eye and your brain have very special mechanisms for seeing the edges clearly. All right, and this allows you to see a sharp boundary between an object and the background. And your mechanism for sharpening edges is called your lateral inhibition, and it works by light sensitive receptors in your eye switching their neighboring receptors off. This makes the edge look more pronounced. So scientists actually don't understand why exactly you see the black dots, but they think it has something to do with lateral inhibition. And I know you're all probably sitting thinking, what is she doing showing us all these pictures? Here's another one. And if you were to look at that picture, you know, is it men working on something that's hanging out over a cliff? Or is it something that's, you know, where exactly are the men hanging underneath? It's very hard to make sense of it. It could be anything. The very last one then is look, are the lines parallel or do they slope? And if you stare for long enough, you will wonder what's going on in this picture. The reason I have put up all of these pictures is that, you know, our mind plays tricks on us at times and our vision plays tricks on us at times, and what we see is not always what's there. And I think that you know, to help people make sense of their psychotic experiences or their mental illness experiences, it's important that we unpick the rationale behind things for people, that we help them to make sense of X and Y have caused Z. I think it's really important that there's not always just one explanation for something, or things are not always as they seem. And I think that that's really important. And we all know people who aren't unwell, but are as grandiose as be damned. They have notions, I think we would call them. We all know people who think things are referenced about them, that everything, the world revolves around them and everything is about them. And we also know people who are as paranoid as be damned, and everything is, everything is a conspiracy against them, but they don't come under the radar of the mental health services. But they are grandiose. They have ideas of reference, and they are paranoid. So we all know people who are that way normally, okay? But it's really, really important to remember that stress can lead to an increased search for meaning and suggestibility, so that people who are grandiose, they might tip over even further into the grandiose bit. The people who are paranoid and feel persecuted, that, that if their stress levels increase, that they do feel more paranoid or persecuted. People's pre-morbid personality, it's important to know what that is as well when you meet them first. Okay, so when do we start using normalization? As soon as possible. I would start normalizing with people who come onto my caseload at my very first interaction with them. When we're sitting and we're having the get to know you conversation and the initial assessment stage, I start normalizing at that interaction. I think it's really, really, really important that people know that there's something else going on besides these symptoms, and that there's a rationale, that they haven't just arrived. Because people will say, I have no idea how I've gotten here, like what has happened to me. I'm just a normal person and yet here I am. So you need to start normalizing as soon as possible. Okay, and why do we normalize? So like I said before, it's to provide an explanation of the puzzling if someone is psychotic and perplexed and distressing symptoms, and to reduce the catastrophic way that people think about them, I think is really, really important. Okay, so how do you go about normalizing for somebody? So it's all based on the stress vulnerability model. My whole practice is factored around the stress vulnerability model. And it's a really, really important way of pitching it to people so that they can understand what's going on for them. This allows you to track back right to the very beginning of the symptoms, so you get a clear picture of what's been going on for somebody. You can explore the antecedents to their illness, and it allows you to identify key stressors and key vulnerabilities. And you can use the information that provides as good a fit as possible to the patient. So depending on what they tell you, you use that information to provide the normalizing experience. The information you get will depend on what way you approach the person in terms of normalization. So I want to talk to you about Mr. A and Mr. B. So Mr. A is a schizophrenic, and he was first diagnosed 6 years ago. He was admitted after being arrested by the guards and detained under the Mental Treatment Act. He is now maintained on medication and has been well for 2 years. So that's Mr. A. Mr. B is a happily married man with 1 child. 6 years ago, he suffered a breakdown following the death of his mother. Only in the past 2 years has Mr. B felt that his life is worth living again. He works part-time to support his family. He's interested in wiring, it's writing about his experiences, and he is active within his church. So that's Mr. A and Mr. B. So how do we go about helping those two individuals? In actual fact, Mr. A and Mr. B are the same person. So if you look at the explanation for Mr. A, it is literally talking about symptoms. Mr. B, it talks about his life in its totality. It talks about his vulnerability, and it talks about his strength. And if we are to really, be holistic, and if we really are to use a stress vulnerability model, and if we really are serious about, psychosocially addressing people's mental health problems, we need to see Mr. B. We need to treat all our patients like they're Mr. B and not Mr. A. I think it's just so important, and I think it's, you know, it's a huge piece, and definitely will inform how we move forward with our practice. So I've just waffled on about this, but we get differing impressions for the short descriptions. Okay. Mr. A reduces our understanding focused around psychiatric terminology, and we have a distorted picture of him as a person and what his capabilities are. So Mr. A, we know nothing about him except of his psychiatric symptoms. Okay, so the stress vulnerability model, what is it? Okay, so the concept actually is fairly simple, but yet at the same time, it kind of frames everything. And it looks at, you know, the fact that our health is influenced by several factors that interact. It is rarely just one thing. There's usually several different things in play for a person when they come to the attention of our services. And it's the relationship between the stress and the vulnerability are the main determinants of the model. So basically, the relationship between what somebody's stressors are and what their vulnerabilities are form the entire model. It also pitches mental health experiences as being normal. So, you know, it looks at people's stresses, levels of stress, it looks at their level of vulnerability, and it actually says, well, actually, given your stresses and your vulnerabilities, it's kind of normal that you're having mental health experiences, mental ill health experiences at the moment. And it also helps people put their mental health experiences into context. Okay, and it allows us to help a person form effective ways of coping and support, and these are really essential for somebody's mental well-being. So what is stress? And I suppose, you know, what is stress? It's different for everybody, but a physiological or psychological reaction to what? Like what stresses me out mightn't stress somebody else out. How many times do we hear it said about somebody, oh my God, that fella's horizontal, he's so laid back, nothing bothers him. Okay. Are there different types of stress? Of course there are. Does everybody, does stress affect everybody in the same way? It absolutely does not. And what happens with long and short-term stress? Okay, so the physical and psychological effects of excessive exposure to stress are recognized in a mental health setting as agitation, anxiety, insomnia, irritability, low motivation, the angry patient, the frustrated patient, patient with poor concentration, and the patient who really struggles to make decisions. And this, you know, in this situation, stress means a force that acts upon our system in a way that puts it under strain. And it really is important to remember that stressors can be either negative factors, such as boredom or inactivity, or pleasant events, such as getting married, buying a house, having a baby, getting a promotion at work. But whether they're good stresses or bad stresses, as in happy stresses, things, you know, you're stressed because you're planning your wedding, or you're stressed because you've lost your job and you're sitting at home all day doing nothing. It doesn't matter what the stress is. The end result is the same, is that it puts strain on the individual. Okay. And within the stress vulnerability model, I suppose there's an understanding that stress is a variable, and this variable influences the manifestation of symptoms, regardless of whether it's a good stress or a bad stress. Okay. So I suppose to really understand this, we need to just go through the differing forms that stress can take. So there's ambient stress. Okay, so ambient stress is the stress of everyday life. You know, every single body, every single person has stressors in their life, whether it's trying to pay bills, whether it's trying to get to work, whether it's schools being closed because of the bloody storm, whatever. Everybody has stress in their lives, okay? And like vulnerability levels, it depends on the individual. So junior doctors will have much more stress in their lives than retirees, okay? And, you know, like I said before, you know, as with beauty, stress is in the eye of the beholder. So, you know, it just depends on what sort of a person you are, how you react to stress. And if you stop for a second to consider your own stressors, you will realize that there's always something. There's always something going on in your life, whether you haven't paid a bill, somebody is sick, your job is rubbish, you have a headache, you have an essay to prepare for college, you have to prepare a presentation. Everybody has stressors in their lives. Okay, so this is what goes on. We all have stress in our lives. So it's, and it's how we deal with it that's important. Okay. The emotional atmosphere within families, so high EE, is huge. It's a form of stress. Yeah. So families who cope better and in a lot of cases who manage to create a climate of tolerance and balance, so they don't ask too much or too little of somebody with symptoms. This reduces the ambient stress in a person's house, and these type of families fall in to the low expressed emotion category. So on the flip side of that, families who find the illness really difficult and tricky to adapt to, they often can become critical of the person, and they're really unaware of the effects of this constant critical narration that goes on in the background of somebody's life. And families become really frustrated with the challenge of having to deal with somebody who's sick. And that's, really stressful for people too. And oftentimes what we see is they completely overcompensate for the illness and infringe on a person's autonomy to make decisions for themselves. And this is it's all out of goodness to ensure that the person is taken care of, but it is very stressful for the person who's sick. So these families fall into the high EE category, and they really unwillingly and unwittingly even increase the levels of ambient stress in the home of the person who's experiencing mental illness. So, this can also apply, the emotional atmosphere can also apply to the mental health professionals. So, within ourselves, if we deal with people who we overcompensate for them, or we patronize them, if we patronize patients, we can increase the levels of ambient stress in their lives as well. So we as professionals need to be careful about the levels of ambient stress that we can create in the home of an individual that we're looking after. Okay, so life stress events, another form of stress. So we all have periods in our lives with high and specific levels of stress. Okay, so when we're buying houses, when somebody dies, when somebody gets married, when we're in college, when kids are sick, when there's a lot going on. Okay, and these are just seen as common experiences. Yeah. Life stress events, as in people who have a traumatic event in their lives. So something awful happens to somebody, or something really traumatic happens to somebody. People often have a psychotic experience for the first time around that event. Some individuals have short-lived psychotic experiences that are strongly linked to life events. And I certainly, I'm sharing now, but when I was having one of my children, I definitely was absolutely bananas. Definitely, I was hallucinating. I had been deprived of sleep for so long, and it was just so difficult. And I actually hallucinated that Brian Cowan had arrived into the delivery suite, and I was utterly, utterly convinced that he was there. So, I don't think that I'm psychotic beyond that experience, but I definitely was in that moment. Brian Cowan was watching me have my baby. And people often hear the voice of a dead loved one who's recently deceased. So there are normal experiences that cause people to become become unwell and have psychotic experiences, even just for short instances. So there was a study to rank life events in order of severity, and from 1 to 12. As you can see them there, I'm not going to read them out, but it's rare that there's one of us who get to a certain point of our lives when one of these things haven't happened to us. So we've, lot of the time we all have had extremely stressful experiences in our lives. All right, so move on to vulnerability then. What is it? Okay, so basically it's, it's to do with the disposition of the person. okay, and how this can contribute to them developing symptoms of serious mental illness. All right. So vulnerability is thought to be determined on two factors. So there's an inborn vulnerability. So you're genetically predisposed. We all know that there's a familial link between, mental illness. If a member of your family has a history of mental illness, your risk of developing mental illness is slightly higher. And it's also reflected in the neurophysiology of the brain. So, if you're deprived of oxygen at birth and things like that. Actually, no, that's an acquired vulnerability. So it's to do with the neurophysiology is to do with the makeup of your brain, and clearly it is beyond my explaining it here today, but it's to do with things that you're born with. The acquired vulnerability, okay, that's very, very specific to the person, okay? It is all very much dependent on a person's life experiences, what they have been through during the course of their lives, okay? And they can include specific diseases, perinatal complications, so whether you're deprived of oxygen at birth, things like that, family experiences. What was your experience of a family life when you were growing up? Adolescent and peer interactions. So how many people have we come across during the course of our practice who have been bullied, or who have had no friends when they were growing up or when they were adolescents, and their previous life events. So that into that category would fall trauma and things like that. So there's lots of things that happen throughout a person's life that make them vulnerable to developing mental illness. Okay, so it's a combination of nature and nurture. And a good example of that would be, children who have been adopted, whose biological parents have a history of mental illness. They grow up in a family without, without mental illness, without any specific traumas, but they still go forward and develop a mental illness because they're genetically predisposed to it. Okay, so basically what the slide there is, so I put that slide in. Mental illness can manifest itself. It can be one or several or loads of, loads. Any one of the above, can contribute to a person's vulnerability to manifesting mental health symptoms. Okay. So there's a very wide range of vulnerability factors and a very wide range of stress levels that can lead to illness manifestation. Okay. So the more stress a person is under, it makes sense, the more health is under their strain, and the higher the probability that their vulnerability will be expressed. And when I say expressed, I mean that someone's going to develop symptoms of mental illness. Okay. Some people have internal protective mechanisms to guard against stress, and they never really reach the level of vulnerability that is necessary to develop mental illness. Okay. So what are those internal protective mechanisms? It could be that they're really good at managing their stress levels, that they recognize that they're stressed and they take exercise, or they do meditation, or they do relaxation, or they practice mindfulness, or things like that. So they never reach the threshold where the stress and the vulnerability levels get to a point that they tip over into mental illness. It's resilience as well. People, grow up and they've had knocks and they've picked themselves up and they've dusted themselves off and they've got over it and they survived that knock, and it makes them hardy for the next knock. And I think that, that's why it is so important that we build resilience in the younger population, that they learn to pick themselves up and dust themselves off and be disappointed. And, life's not perfect. But hey ho, be upset, be disappointed, but at some point, find ways of dealing with it and move on. Okay. So the stress vulnerability model in itself. So this was very first suggested back in 1977 by Zubin and Spring. And all of the stress vulnerability models and conversations and everything that goes on are pretty much based around this model in itself. Okay, so with my diagram there, I don't know, can't even remember what sort of a diagram that is. But anyways, if you look along the bottom, it's vulnerability. And if you look up along the side, it is stressful life events. So under the curve is mental health or mental wellness. Over the curve is mental ill health. And the line, the squiggly line, is your stress threshold. Okay, so if we go back to thinking about early experiences, personality traits, important life events, physical disease, and socialization, right? These are all stressful events in a person's life. Okay, so if you've got loads and loads of stressful events, you're going to be up towards the maximum on the stress events side of the scale. Okay, if you have a low vulnerability for mental health, it doesn't matter. You'll have a huge amount of stressful events in your life. So we're looking towards the left of the diagram as you look at it. You'll have a huge amount of, you can have a huge amount of stressful events in your life, but you never tip over that stress threshold line into mental ill health. But if you have a low vulnerability or a high vulnerability to mental health, it doesn't take very many stressful events for you to tip over the squiggly stress threshold line into mental ill health. So I'm hoping that makes sense. I always feel that this is the type of stuff that does better in a classroom setting. You can kind of draw it out and make more sense of it. So then this is the same kind of thing. It's just depicted differently. And it's from the Nottinghamshire MHS Trust team, and I do have their permission to reproduce this. And actually, this is actually a really good depiction of stress and vulnerability as well. And the triangle at the bottom is and the line at the bottom is a seesaw. Okay, so that depicts a seesaw. So the seesaw moves between mental distress and mental well-being. Okay, so personal vulnerability and coping. So a person's vulnerabilities and their coping styles and their environmental stressors. Okay, if they have lots of personal vulnerabilities, poor coping strategies, and lots of environmental stressors, the likelihood is that the seesaw is going to tip to the mental distress side. If, on the other hand, they have lots of personal protective mechanisms and lots of environmental supports, and if you look at the supports should actually be on the other side. It obviously moved. The seesaw is going to tip to the well-being side. So that's the way they've developed it. So it's a seesaw, and it depends on what's going on in any of the sections of the square there, will depend on how the seesaw tips. Okay. So when we're looking at all of this, we need to look then at how a person copes. Okay. And every one of us copes differently, and it's very personal. Okay. And it just depends on your personal attributes. Okay. But the way we react to things and how we deal with things is termed as coping. Okay. And when we talk about coping, a lot of the time you think about coping as being a positive thing. However, there's lots of negative coping strategies as well. And I think it's really, really, really important that we have conversations with people about their coping strategies and their coping styles, because if they're using negative coping strategies time and time and time again, well, then things aren't going to improve. Okay, so positive coping. So that's a way of ameliorating the strains and reduce the stressors. Okay, whereas negative coping is where the stress and resultant strain is intensified. Okay, so when we talk about negative coping, we're talking about people who go out and get absolutely plastered, people who cut themselves, people who take drugs, people who bang their heads off a wall, people who shout and roar and scream. They're all negative coping strategies. So they might result in, a relief of the symptoms or the stress in the short term, but in the long term, they're not very effective. So nothing has changed. A person has cut their arm to bits, and the stressors are all still there, and their arm is in bits as well. So that, what we need to be looking at with people is their coping strategies, their coping styles, and if they are appropriate coping strategies, and not just appropriate ones, but effective ones. You know, you don't need lots of effective coping strategies, you just need one or two. So can you think of your own negative and positive coping strategies? You know, what do you do when you're feeling really stressed and the wheels fall off the wagon? And can you think of negative coping strategies that your patients are using? Okay, so coping and the stress vulnerability model. So it all will start to make sense and come together now. So coping can influence not only the possible onset of psychotic symptoms, but the course and prognosis of an illness. So if a person is using negative coping strategies time and time and time again, nothing is ever going to improve and nothing is ever going to change. Okay, so if we can steer people in the direction of positive coping strategies, things can only get better. All right. So what influences a person's coping ability? So their personality. Are they overdramatic? Are they the type of person who just goes, oh, this is just my lot in life and there's just no point doing anything because that's just the way it is. You know, their culture. If you think about how culture influences how we cope, if you think about, we'll say, in African places where somebody has died and you just see all of the women sitting wailing and wailing and wailing, that's their coping strategy. That's how they cope. So it's often affected by your culture. You know, is a coping strategy that you get the witch doctor in because somebody has put a voodoo on you, or you know, is practicing voodoo on you. It will be influenced by your culture, your family experiences. So how do the rest of your family, how did your parents model their coping strategies? What is it like at home? Is it a supportive coping environment or is it a negative coping environment? It'll depend on a person's education. What have they learned? Are they looking online at ways to manage their stress or manage, you know, their ill health? Are they meditating? Have they learned that relaxation is the way forward? So, and their education, an awful lot will influence their ability to look for ways of coping and to seek it out. Their mental health practitioner, and this is huge, and a lot of people wouldn't even give too much credence to this, but we as practitioners have a huge influence on how people can cope. So, like, are we psychosocially focused? Do we look at psychosocial ways of a person coping? Are we solution focused? Do we help people find solutions to their problems? Or are we just firmly embedded in the medical model? Because if we're firmly embedded in the medical model, well, then we'll think that medication is the answer to everything and we don't need to look at anything else. Okay, so coping strategies, they're the specific efforts, both behavioral and psychological, that people employ to master, tolerate, or reduce or minimize stressful events. So we can't take stress away from anybody. Like stress and, you know, anxiety and the ambient stuff, it's kind of normal. But it's about having these things at a level that make it easier to function and to cope. So two general styles of coping have been distinguished. So problem solving coping strategies is one. Okay. So these are the things we do to alleviate or manage stressful events. Okay. And they're designed to change the nature of the stressor itself or how one thinks about it. And these are referred to as the acting coping strategies that we focus on. And then there's emotion focused coping strategies. Okay, so how do we regulate our emotional arousal in response to a stressful event or a potentially stressful event? So these type of emotion focused coping strategies can be avoidant and lead people to activities such as alcohol use or mental states such as withdrawal, and it keeps them from directly addressing stressful events. So how many avoidant people do we come across in the course of our practice? I think we find that there are an awful lot of avoidant people out there. And it's, it's important that we recognize these avoidant behaviors for what they are and to try and help to change them. Okay, so cognitive coping strategies. Okay, so these apply a person. These require a person to apply conscious mental processes to their mental distress. Okay, and it helps them to tolerate or reduce or master the stressor. Okay, so concentrating on a particular item other than a stressor. Okay, so changing your focus, thinking differently about the nature of the stressor. So those negative automatic thoughts that we have, we need to switch them around. Or thinking differently about one's control over the stressor. If somebody thinks they have no control over the thing that's stressful for them, it's really, really difficult for them to address that stressor. So it's really important that we allow people to exert some control over the stressor, and even having them thinking that they can exert some control over the stressor. You always just go in for a small win at the start, and build on it from there. So other cognitive coping strategies: attention switching, puzzle books, repeating a phrase, mindful colouring, those type of things. When you're talking about somebody who's hearing voices, and how do you deal with, if somebody's hearing voices constantly and the distress that causes them, can they focus on the characteristics of the voice, whether it's a nasal tone, whether they speak slowly, whether it's, high pitch, low pitch, whether they whisper, whether they talk loudly, as opposed to what the voice is actually saying. Sometimes the levels of distress come down. Self-instruction, positive self-talk, reality testing. It's another big one in CBT as well, especially with psychosis. Okay, so look for the reality. Look to try and shake somebody's conviction about a particular idea or thought that they have. So physiological ones. Okay, manipulating their level of sensory and psychological arousal. Okay, so do you go and sit in a dark room? Do you put on soft music? Do you put a weighted blanket? Do you lie under a weighted blanket? Okay, so these are all ways of, tolerating or mastering the stressor. Okay, so you alter the level or the type of external stressor or the external sensory input. Okay, or change the level of cognitive alertness so that people can switch down their level of alertness so that they're better able to cope. Okay, so sensory strategies. So modification of the sensory input using earplugs while you're listening to music. Using earplugs, or listening to music to drown out the sensory input or to drown out the voices. Okay. And the physiological strategies. So how do you modify somebody's physiological state? Well, you teach them how to learn to relax. You allow them to see the benefit of exercise. Another physiological strategy would be medication. And alcohol would be a coping strategy that would be used quite a lot, and it will help in the short term, but in the long term, it doesn't. So behavioral strategies. Okay, so these are the things that the behaviors that people actively engage in to increase or decrease their physical exertion, or it's an occupational type of activity. So what I'm talking about here is, do people sit and do nothing? Or do they avoid doing anything and get worse? Or do they increase their socialization? Do they start mixing with people? Or do they start engaging in physical activity or physical exercise in order to help them to cope and to burn off the cortisol and the adrenaline that the stress is introducing into their lives? So I've just spoke about that. Physical exercise, walking, gyms, and increasing their social activity. Like I do say to people, the doctor has prescribed you this course of medication, and I'm prescribing you a 20-minute walk each day, 10 minutes away from the house, 10 minutes back. The walk is as important as the exercise. I think it's really, really important. People need to be engaged socially. It's really, really important. And they need to, it's, you know, as a positive coping strategy, it's really, really important that people are engaged. Decreasing social activity, withdrawing is another coping strategy. It's just not probably a lot of the time the most appropriate one. So it's really, really important, right, that when we get and meet people for the first time, that we explore and identify their coping strategies. Okay. So, and in terms of that, it's really, really important to establish with somebody, how do you cope? What do you do to cope? Yeah. How often do you deploy these coping strategies? Do you do it every day? Do you do it several times a day? Do you do it once a week? Do you do it twice a week? Yeah. And the really key thing about all of this is to look at the effectiveness of the strategies that they're using. Because a lot of the time, what we will see is that the coping strategies that people deploy the most frequently are often the least helpful. So I drink every night because it helps me to relax. Well, it does, but you wake up every morning and you feel like crap. So you're deploying this coping strategy every single day of the week. And in the short term, it works, but in the long term, it adds nothing of value to your way of coping, but you use it every single day. And we'll say that person had said, once a week, I meet my sister and we go out to lunch or we go shopping or something like that. And that's, you know, that works really well. I feel really good after that. So then you can turn around and you can say to that person, well, look, you're saying to me that you drink every night of the week as a way of coping, but you feel really shitty the next day. So that's a coping strategy that you use. It's just not an effective one, but you do it every single day. And you tell me that on the days when you're more socially active, i.e. you go out and you meet your sister for lunch or do whatever with your sister, that you feel really good after that, but you're only doing that once a week or once a month or something. So would it not make more sense to do more of the meeting up with people and being socially active and less of the drinking in terms of an effective way of doing things or an effective way of making yourself feel better? So it's really, really important that we look at the effectiveness of people's strategies, because from my 20 years in psychiatry now, a lot of the time when people arrive in mental distress, they use the negative coping strategies are far more prolific than the positive ones, and it's looking at switching those. And then if they don't have any positive coping strategies at all, then you need to look for positive ones. So that's, you know, an alternative coping strategy from the drinking or a new coping strategy. I think that's really, really important. So I'm going to move on to the stress vulnerability model in terms of the stress bucket. Now, this is also something that I would use with every single solitary person that comes my way in terms of my practice. It's not big, it's not fancy. I have a blank sheet of paper and a pen, and we draw it out, and the person is involved in it. But there's a short video coming up, and Anya, if you could take the screen and play the YouTube video now, that would be great.
Yeah, no problem.
Thanks.
Can everyone see my screen?
Yep.
Perfect. Can you hear it?
Yeah.
What is stress? It's the physical and the mental changes we experience as a result of the demands placed on us in day-to-day life. So what does a bucket have to do with stress? The stress bucket represents our capacity to cope with stress, and the water level is the stress load. The more demands or stresses there are in our life, the higher the water level, and we feel stressed. Let's look at the different types of stress. There are the stressors that we choose, such as moving house, starting a new job, or going on holiday. And while mostly a source of joy and comfort, family, friends and relationships can also place us under stress. Work stress is a common problem and can include workload, flexibility and personal relationships in the workplace. And we all understand the financial demands of having a mortgage, bills to pay and family to support. We can also get stressed from our environment, including what we see in the media, our neighbours and even the weather. Plus, sometimes we hold attitudes and make lifestyle choices that add to our stress. And when the demands or stressors become too much, the bucket overflows and we can't cope. There are, however, ways to make sure your stress bucket doesn't overflow. You can reduce the amount of stress in your bucket by making choices, problem solving, or asking for support. And you can grow the size of your bucket by building your resilience and skills level in coping with stress. Remember, your thoughts, body and feelings are all connected. So if you go for a walk or visit a friend, even when you don't really feel like it, you may end up feeling better able to manage. But be aware, some short-term fixes to stress really make it much harder in the long run. We all carry our own size of stress bucket. Some buckets are larger than others. But what matters is that you can carry your own bucket comfortably without spilling a drop.
Okay. Just bear with me now for a second and I'll take back the screen. Here. Okay. So that's actually a really, can everybody hear me there again?
Yeah, we can see and hear you fine.
Okay, perfect. Yeah, that's grand.
Yeah, I can hear you.
Yeah. See, my stress bucket's overflowing now with the technology. The technology today, it's not my friend. Anyways, so that's actually a really good video. Even it's a useful video to show to people if you're struggling to explain the concept to them. So, but basically that 2-minute video explains everything that I've just spent the last hour and 5 minutes going through with people. But it's quite a simplified version of it, but it really helps people make sense as to how their bucket overflows. Okay, so this is a much more elaborate explanation of it. Okay, but this is, you know, just in terms of ourselves in order to make sense of it all. Okay, so up here we have our academic stress. Okay, so these are all the different types of stressors that people can have in their life. So if you're in college, chances are you're going to have some academic stress. Okay, interpersonal stresses. Okay, so these are our relationships that we have, whether it's people we share houses with, whether it's parents, our friends, our girlfriends, or our boyfriends. We have interpersonal stresses. And this also includes your physical health. So intrapersonal stresses includes your physical health, your financial situation, your mental health issues. So if you already have depression and anxiety, you have more intrapersonal stressors than somebody else. Your environmental stressors here, okay? So the things in your work and your living environment, okay? Whether it's, you know, whether it's new or unfamiliar situations. So for me, certainly this presenting on Teams, I find, you know, quite stressful. So it's a new and unfamiliar. I've done it before, but it's unfamiliar to me. I don't do enough of it to be comfortable with it. So it's definitely an environmental stressor for me. Okay, the contract and also conflict, excuse me, between people you live with, whether that's your kids, whether it's your husband, whether it's your parents, whoever it is. Okay. So they're all the things that go into the bucket. Okay. So they're all waters that go into the bucket. Here we have a tap at the bottom of the bucket. Okay. And this level here at the bottom, okay, is our stress levels. Okay. And that's the water. So there's always water in the bucket because there's always stresses in our lives. Okay. But it's the distance between the top of the water and the top of the bucket. That's called a buffer zone. Okay. So that's the level between, you know, your mental health and your mental ill health. So the taps then represent ways of coping. And this tap here is recycle stress. So when we talk about unhelpful coping strategies, So the drinking, the alcohol, the drinking, the drugs, the self-harm. So while these may lower the level of water in the bucket in the short term, all they do is they recycle themselves like the rainwater and just go back into the bucket again. So what we're looking for and what we spoke about earlier on are the problem focused coping skills and the emotional focused coping skills. Because if people have both of these and they're able to use them, they are constantly able to have that tap turned on so that when all of these things at the top are adding water into the bucket, the taps are letting the water out at the bottom. So the water never gets up to the top of the bucket and it never gets to tip over. So that's basically what that is. Okay. Now, I want this move on for me now. Okay. So the coping and support will help the bucket to stop overflowing. So we all have a stress bucket, and entirely up to yourselves whether or not you decide to have a look at this. I know that here I would, even though I live with a man who has nothing to do with mental health, he knows about stress buckets, he knows about these kind of things, and he will know that if I say my bucket's about to tip up, that things aren't good. So everybody has a stress bucket. And I think it's important that our patients understand that I have a bucket, you have a bucket, we all have a bucket. And just depending on where we are in our life, depends on where the water is in the bucket. Now, I don't bring this sheet with me. I literally arrive with an A4 sheet of paper and a pen, and we sit and I draw the bucket and I say, this is the bucket. This bucket represents your mental health. There's always a drop of water in the bottom of the bucket because there's always things that go on in our lives that causes us stress. However, let's talk about the last year or the last 6 months for you. What has been going on for you? Talk about the stressful things that have gone on in your life. And we sit and we write all of those things along the top of the bucket. And I go, that's water that goes into your bucket. That's more water that goes into your bucket. And then we talk about how you can cope and things you can do to help yourself cope. I always talk about, interaction with the mental health services, engaging with the psychosocial process, taking the medication if that's what's required with you, doing the relaxation, doing the exercise. They're all put down at the bottom of the bucket in terms of these are things that you can be doing that keeps the levels down in your bucket. I hope that this is making sense. If I was with you in a room now, I'd have a whiteboard and I'd have a pen and I would show you exactly what I mean. But this actually creates an absolute dialogue between you and the person, and it helps them to visually see that, oh my God, yeah, there's loads been going on in my life for the last year. And I just thought that I had flipped because I'd had a row with my mother, but if a person can see that there's been so many other things contributing to their mental health, it helps them make much more sense of what's been going on for them. Okay, so what are the other skills that we can use when we're talking about looking at somebody's helping somebody to make sense of their mental distress? Okay, another skill that can be used is a timeline. Okay, so timelining is one of the key concepts of the stress vulnerability model, and it also looks and helps people make sense of that oftentimes there's a correlation between the stressful things going on in someone's life and the manifestation of their symptoms. And this is often a huge piece of work that can't be done in one sitting, and it can take several sessions, and you'll leave it and you'll come back to it and you'll ask family members to take part in it. And it's really, really visual, and it's actually, it really is able to, it really is helpful in allowing people to see the correlation between that time in my life when things were really, really difficult and I was really, really stressed, and actually that was the time when I got sick for the first time. Okay, so what is a timeline? It provides an overview of a person's social history, their significant life events, that and the manifestation of their psychiatric experiences, and it looks for the links between the two. Okay, it's really, really practical and effective. Okay, and but like I said, it's a huge amount of history and data taken from an individual, and people's case notes are often a good place to go looking as well. Okay, so what we know about depression is that life events play an important formative role, and they're of big significance with somebody who goes on to develop a depression. And in schizophrenia, life events also play a trigger role, and that sometimes they aggravate a strong pre-existing tendency towards a psychosis. So somebody who's a pre-existing, you know, predisposition to becoming psychotic, who's bullied in school, you know, that increases the likelihood, you know, their stress levels and the likelihood of them tipping over into a psychosis. Okay. And it has been found that life events in the preceding months are significantly greater than in the months not followed by an onset. Okay, so when things are ticking along nicely in life, chances are you're going to stay well. But when there's lots of life events going on, whether it be moving house, getting married, getting divorced, death of a loved one, or something like that, they all tend to be something big like that tends to be going on in a person's life in the months before they come unwell. And it also finds that if you can go back and talk to people when you're doing their timeline going, well, when I had stopped taking my medication, well, I was okay for 4 months, but then we tried to move house and I became really unwell. So it's a really good way of exploring whether people were or were not taking their medication at the time. Okay, so how does a timeline look? Now, I have it here, I have it side by side here just for the visual, but when I'm drawing it out, I tend to have an A4 piece of paper and I tend to have it on the landscape as opposed to portrait. And I have the important events in my life on the top of the line and the consequences on the bottom of the line. And I literally, it's like a continuum, and we start off with when you were born, go to school, we work down through a person's life, you know, secondary school, college or work or training or whatever. And we literally go through step by step of someone's life. It is a fabulous way, an absolutely fabulous way of getting to know somebody. You get so much really rich information of people when you do a timeline with them. And it also lets you look at how a person looks back on their mental health experiences in the past. You know, are they the same? You get to explore, their entire history, and it's a really, really good way of getting to know somebody and about their lives. And actually, it's really non-threatening. It's actually a nice thing to do with somebody. So this one here is, mom was in and out of hospital, so I'd stay with my dad, my stepmom, my auntie, and went to loads of different schools. So that part of their lives was a lot of disruption. Really upset, felt that mum didn't love me, didn't want to live with my dad. He was awful, so I ran away to my grand's. So there was lots of stuff going on. Bullied in school, didn't have a lot of friends, couldn't concentrate on my school, felt confused and started to have really bad nightmares. So that's all happening in around the same time. Then go on to 1986, started college. But when I was there, I started to panic when I was out with groups, miss out on classes, and made me fall behind with my work. So you can see that college, the consequences and the stress of starting with college, the symptoms of panic started to develop. The following year, I was really worried about my exams and I missed out on a lot of college. I felt really unreal, out of control. I started to smoke pot, which relaxed me. So there's the first nod at a negative coping strategy. So it worked, but it didn't work. 2 years later, I fell out with my girlfriend after drinking too much at a party. She got angry for something really silly. Okay. How did I feel? Really upset. She was the only one who understood me and thought the people were getting at me. Okay. So that's the way it kind of works. You go through people's life. Some people, if they're only in their early 20s, they'll have quite a short timeline. Some people might have quite a long timeline. And that's why it often takes lots of time to get through it. But it's just really, really important. And what I tend to do then is when I have the timeline complete, I highlight with a highlighting pen. I go back over, it's all handwritten, it's all so like back in the 1980s, but I'll get a highlighting pen and I'll go back over the times when people's mental health has been suffering. And I'll go, well, look, this is what was going on in your life and you became unwell. Do you see the link between not taking your medication or being really stressed out or drinking loads or taking loads of drugs? And people can very pictorially see the link between the two. So I've just said all of that. Case notes can be integrated into the format. So, you know, there are challenges. It's not all easy peasy lemon squeezy. You know, there are challenges of developing a timeline. I'm just looking at the time here now. So issues to be aware of when we're looking at people's timelines. What do we need to be aware of? People's memory mightn't be the greatest. People's memory of times when they were unwell mightn't be the greatest. It is often useful to have a family member involved. People often have cognitive impairments. Be mindful of that. Okay. People who are on lots of medication might not necessarily, their memory mightn't be as sharp. People who have negative symptoms, there are some people, and it's like trying to pull teeth to try and do a timeline with them. Be very aware of the fact that if you're doing a timeline with people, if they've had traumatic events in their lives, that you do not want to re-traumatize them. And I think that that's really important. I think, you know, it's all too easy for us to go in and re-traumatize somebody and then walk out the door and they're left sitting in the midst of being completely re-traumatized. I think we need to be very, very mindful of somebody who has a history of trauma and how we deal with it. And also the fact that when somebody's life is laid out in front of them and they've had 5 or 6 episodes of psychosis or depression or, you know, suicide attempts, it can be guilt inducing. So you just need to be aware of that. It's not always easy for somebody to think backwards. So timelines, it's really, really, really useful way of gathering information, and it provides the building blocks. Okay, the information is already there and it'll allow us to look at the genetic vulnerabilities and all of the significant life events that have happened throughout a person's life. Okay, it allows us to look at persons' vulnerabilities, at the stresses in their lives, and at the impact it has had on their mental health. I'm just conscious of the time now, so I'm actually going to fly on to a social network map. So when we think about a social and our own social networks, some of us have large social networks and some of us have small social networks. And a lot of that is personal choice. Some people like to have 1 or 2 close friends. Some people like to have lots of friends. And for us that enjoy a reasonable standard of mental health, we often have good social networks. However, that's not always the case for the people we look after. Okay, so social network is a term used to identify individuals' social ties. Okay, and it's the notion that individuals are in some way communicating and affecting people with the way that they communicate with each other. Okay. In general, not always the case, but in general, the larger the social network, the greater opportunity you have for alternative sources of support. However, some people have quite small social networks and they get a lot of support from just one significant relationship in their life, as opposed to multiple superficial relationships. So some people having a large social network works well. In other cases, not the case. Okay, so social support can be really, really helpful during times of stress. Okay, or they can often prevent stressful problems from becoming severe. Okay, conversely, it can also be problematic due to excessive, intrusive, and overtly damaging relationships. So they can either be good or bad, just depending. Okay, so they're either a stress buffer or an environmental protector, or they can be a toxic environment, which leads them to be an environmental stressor. So depending on what sort of a social network you have, it can either work in your favor or can work against you. Okay, so And the literature out there would suggest that people who have schizophrenia or have mental illness and chronic mental illness, they have smaller social networks than the rest of the population. Okay. And with every episode of illness, a person's social network shrinks back further. Okay. And the earlier that somebody's illness comes on them, so if you're psychotic since you're 16, 17, you're much likely to have a much smaller social network than somebody who becomes psychotic in their 30s or 40s. Okay. So why are social networks important? Okay. So if we think about times in our lives when we've been stressed out or worried about something, you get to talk about it, you get to vent. You get to run things, you can test reality, you get to run things past people. Like, am I being sensitive, or did this really happen? Or, you know, it offers us material support. Somebody realizes that you're financially struggling, or that that you're struggling with something in a material way. They can help you with that. There's a sense of role modeling. So do we have good role models from our social network? People who were in our social network can also help us in terms of monitoring our symptoms. I don't think you're well. I think you're really stressful. I think you're really stressed. I think you're really struggling at the moment. I think you should do something about it. People help us to solve our problems, alternative ways of looking at things. Just having an empathic ear can be also important. And the reciprocal relating is important. Yeah, I felt like that. Or yeah, those, I often felt like that. So what we know about people with mental health problems is that they have smaller social networks. Okay, so there's fewer members. And what we really see with people who have chronic and enduring mental illness is that a large proportion of a person's social network are families and carers. They have few intimate relationships, and an awful lot of the relationships they have are perceived as being, less than supportive. So when you're trying to coax somebody to attend a day centre or a facility, or, I really think that you need to address your social isolation. It's a really useful thing to sit down, and this is like the simplest thing in the world here. It's a social network map. And I sit with people and I say, right, let's look at the people that you spend time with. Who are they? Are they male or are they female? Do they go into the center circle here? So do you spend less than 45 hours a week with them? Do you spend, more, or do you spend more than 35 hours a week with them? Do you see them frequently, or do you only see them occasionally? And what we'll find is that a lot of the people who spend more than 35 hours a week with somebody, it's a direct family member. And what we know is a lot of the time that spending time with a family member, especially if there's high E in the house, can be really, 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 really stressful. And while they might be supportive, they're stressful as well. And you can say to the people, like, who's really supportive and influential in your life, and if they only see them very occasionally, you can go, well, look, this is your life, these are the people you spend time with. Do you not think it's worth your while looking to expand your social network a little bit further, so that you can be in a position of more supportive and influencing relationships on your life? So it's just a very easy way of sitting with someone and, getting them to see that actually I'm quite socially isolated, and actually I'm quite lonely. Yeah. So just to finish up, I think there's the last slide here now. Okay. The process of normalization of symptoms provides a rationale for the experiences that somebody is going through. And the stress vulnerability model goes some way in helping our patients to make sense of their experiences. Okay, so the timelines, the bucket, the social network map are only really the tip of the iceberg, but they are such easy, user-friendly ways of getting to know somebody, of getting to form a care plan with someone, and it, care planning, and people are going, yeah, whatever. But if you've done this piece of work with people and you're sitting then to formulate their care plan with them, they themselves can see the rationale for, it's important that I go for a walk. It's important that I go to Rainbows. It's important that I, get on some sort of a training scheme or something. A person can see the importance of it, but it also helps to normalize their experiences so that they don't feel like they're gone completely mad and that there's no hope for them. So if you pull all of those things together, it can form a huge part of a person's experiences. So that's the end of the presentation. And just on time, actually, I think. I'm just wondering, is there any questions?
You can turn on your cameras now and take yourselves off mute. Oh, there you go. If you want to ask Sinead questions or pop them into the chat box function either, but certainly feel free to turn on your cameras and ask directly. No. I was optimistic there that there was a question. I don't know your name. There's a girl there with her headphones on. Hello. I'll give it a few seconds, Sinead, just in case there is a questions coming into the chat box.
I hope that makes sense for everybody. It's really disconcerting to try and talk to a blank screen when you don't have faces looking back and nodding. You're unsure if it's making sense for people or not. But I hope that makes sense and that people have one or two little tricks up their sleeves now for when they're going out to see their patients.
Aisling said, thank you. Such an accessible, practical approach with food for thought in our work and everyday lives. Yeah, I would second that too. And I love that stress bucket. I think that's really useful for me anyway.
Yeah.
Oh, there's a question. I don't know your name. You're wearing a blue jacket.
Oh, hi. Hello.
Hi.
Hi. Sorry. My link didn't work, so I missed the start of it. It tracked as my name in the matter. Will you be sending on an email of the notes from today?
Yeah. So I think Anya has put up a registration form. There should be a link to it there, and anybody who registers will get a copy of the slides. And also, I think it's recorded as well, so it'll be there so you can watch it back in your spare time.
Thank you. Thanks.
No problem.
Thank you. Any other questions? I don't want to delay you. It's just 12:30. So if there's none, I will let you all go, but obviously I want to just finish by thanking Sinead Frain so sincerely. Sinead is an honorary associate teacher here in the faculty, and we're so delighted and really lucky to have her expertise with us. And you can see her again next week, appearing
at my kitchen table week. Again.
Yeah, she's here next Wednesday for our last session for the P&A collaboration from 11 to 12:30. And next week she's going to talk about working with patients to seek early intervention in relapse. So again, just to flag that for you. But thank you today for what you've done, Sinead. Excellent information. And I know it's very hard to talk to a blank screen. So it was really informative. And I hope like that lots of people can take things back to their own practices is the key thing here, that we're sharing information and important knowledge. So as always, thank you to Anya Halligan behind the scenes. None of us managed without Anya keeping us on the straight technically. There'll be no webinar without Anya.
Thanks, Anya.
And I know it's still a bit stormy out there, so stay safe, everybody. And I know some of you might be around the country where it's a little bit windier. Then Dublin isn't too bad at all, to be honest with you. So be careful. And if we don't see you next Wednesday, have a peaceful Christmas and best wishes for the new year. Sinead, thank you so much, and we'll talk to you next Wednesday.
Not at all, Catherine. Take care.
Bye.
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 Thanks, Sinead.
Bye. Bye. Bye.
Bye.